Now I call upon the previous speakers, Dr. Amnish and Dr. Chaudhary, to take their seats here and to take the questions.
Good morning to you all. And we have 20 minutes for discussion. There are numbered standing mics. There are 6 mics in this hall. So delegates who want to ask questions can come to the mic and ask their questions. We welcome all the delegates, the eminent obstetricians and gynecologists who have accepted our invitation and come and grace the occasion. Thank you.
I am Dr. A.K. Basu from Kolkata. My first question is to Dr. Abdi Singh. Nowadays we are talking about vitamin D level, and some studies have come out that supplementation with vitamin D will improve the outcome in pregnancy, maybe pre-gestational or gestational. What is your take on this vitamin D supplementation? And second question to Professor Shubhankar Chaudhary. As we have alluded all the major points, and sometimes the patient have T3, T4, TSH in the desired range, but the anti-TPO antibody may be on the higher side. And there are some evidences that anti-TPO antibody positivity is also met with some unfavorable outcome during pregnancy. What is your opinion? And in case of thyrotoxic patient have conceived, and during the pregnancy period, I think TSH receptor antibody assay, if available, will give us some clue regarding the risk of the offspring. So these 2 questions.
Yeah, fine. So regarding vitamin B and pre-gestational diabetes, there is no data to suggest any benefit of vitamin B supplementations to prevent any kind of maternal and perinatal mortality. There are some, observational data which suggested that supplementing vitamin B12 might help, but this cannot be recommended.
Vitamin D.
Oh, fine. Vitamin D. Oh, I mean, the entire this data of vitamin D, relates to the diabetes, not in pregnancy, but this data, as I said, if you talk about the extra calciumic benefit of vitamin D, which we discussed yesterday, there is no emerging evidence which suggests by supplementing vitamin D you can do anything good to pre-gestational diabetes.
Shall I? Dr. Basu has raised important issues which pertain actually to management of thyroid abnormalities in pregnancy. I was just trying to cover the deciphering of the thyroid function test, but those are important. The thyroid peroxidase antibody positivity has indeed been shown to be associated with adverse pregnancy outcomes. And there are also studies which have shown that if you give thyroxine to these women who have just positive thyroid antibody, but the TSH is within the normal range, there is better or improvement of the pregnancy outcomes. But at this point of time, this is still an open field, and possibly my action in these instances will be to follow up closely with repeated TSH assay, and if the TSH crosses maybe let's say 2.5 or 3, then only at this point of time I advocate thyroxine treatment, not otherwise. The next part was thyrotoxicosis. Pregnant women, women who are thyrotoxic getting pregnant. The role of TSH receptor antibody, yes, there is a role. Even those who have been treated in the past and maybe euthyroid now, but who have been known to be hyperthyroid in the past, the TSH receptor antibody may be persisting. So it's useful when you have a proper good TSH receptor antibody which actually measures only the stimulating antibody. You could have a blocking antibody as well. So measuring the stimulating antibody, which is not commercially available by and large, can give us an idea what are the risks of the offspring being also affected by hypothyroidism, which of course, however, is usually transient in nature. But thanks for those important questions.
Okay, my question is to Dr. Singh. I find that in the Canadian guidelines, there is no recommendation for doing thyroid function studies in the pre-gestational diabetes, nor either complete thyroid function test nor antibodies. So that was a bit of a surprise because I think the general recommendation is to include thyroid function tests also in pre-gestational diabetes.
Yeah, ma'am, I have mentioned about measuring TSH level, and that is, related with type 1 diabetes. If you talk about, universal screening with the thyroid function, it is not yet recommended, but the data suggests that somebody having a type 1 diabetes and pregnancy, they must be measured with TSH.
So my question is with the thyroid function test and pregnancy, sir. Suppose the patient's, the mother's TSH values ranges between 3.5 to 5. And is it necessary before starting the patient on L-Traxine to do TPO antibodies test?
No, if the TSH is already in a range which we agree should be treated, then it does not matter much. However, if the TSH is normal, and if you have an antibody positive, then you need to follow up with more frequent thyroid function tests, and you need also to be alert that in the postpartum period, that lady is more likely to develop postpartum thyroiditis. And so do a TSH at least at 6 to 8 weeks after pregnancy, after delivery.
What is the lowest range of TSH above which we can boldly start L-Traxine, sir, for the patients?
At this point of time, possibly the lowest would be 2.5 microunits per milliliter.
At any time of pregnancy, if it is more than 2.5, we can boldly start the patient on L-Traxine.
Yeah, I mean, that's before planning pregnancy. The goal is to have it within 2.5, including the first trimester, and beyond first trimester, 3 is the lower limit.
So what is supposed to be the dose, sir? If it is a overt hypothyroidism, we can start with the same dose of that one, calculate, and suppose it is a subclinical hypothyroidism, the patient is not morbidly looking like a hypothyroid patient. So what would be the dose we can start? Can we start with 25 micrograms or 50 micrograms, sir?
But it's partly it will be based on the mother's weight as well, but roughly about 50 micrograms in someone weighing at least about 50 kilos would be a reasonable dose, but you need to of course follow up.
Follow up, how far we can follow up, sir? Because pregnancy is, of course, a 10 months fantasy, we are supposed to follow up on a very regularly.
So you need to measure the TSH again after, I mean, there would be recommendations at 4 weeks, but I wouldn't do it before 6 weeks. At about 6 weeks, we should remeasure.
Thank you, sir.
Hello. I would like to answer some of the questions, not answered from the first questionnaire. He asked, in the presence of normal T4 and T3 with raised TPO antibody, what to do? Actually, the laboratory guidelines to measure thyroid function tests during the pregnancy is you should not do total T3, total T4. You should do only free T3 and free T4 because there is a protein binding problem. And the second thing is chemical pathologists consider if there is a normal thyroid function test, but there is a raised TPO antibody, that is an evidence of autoimmune destruction of thyroid tissue is going on. So, and I was also, there is an evidence that during the administration of T4 in those cases, the abnormal thyroid TPO antibody level come down to normal. And also there is another point I would like to emphasize at this point. During the pregnancy, for every trimester, there is an established reference range you should follow. You should not follow adult reference range or children reference range for those subjects. And that should be, that is where the laboratory comes into the effect. That should be, reference range should be generated locally for the local population, because the ranges suggested by the literature and by the manufacturer is from the Western population. So these are 3 points I would like to emphasize for the clinical community at this time.
Thank you for your comments. Maybe I suspect you were not able to be present during my presentation. It does sound good that we should take recourse to free T4 rather than a total T4 measurement in pregnancy, because TBG does rise and total T4 does rise. However, as I have shown in my presentation, even free T4 measurement in the way that we do in most commercial laboratories is open to fallacious results. And so even free T4 is today not found to be superior. In fact, people have gone back to measuring T4 and trying to keep a level within 1.5 times the upper non-pregnant level. And in terms of TPO antibody measurement, I did mention that the use of thyroxine in individuals whose TSH is normal, T3, T4 are normal, but just a TPO antibody positive in pregnancy is still open to discussion. There have been a few studies to suggest that this does improve pregnancy outcomes, but it is not yet universally recommended. What was the last but laboratory is of course important, and pregnancy specific, trimester specific values should ideally be developed, but it's quite difficult to have to ask the commercial laboratories to develop these normal ranges for a population. So it has to be some institutes, it has to be maybe some august bodies, maybe FOGSI or maybe Endocrine Society. And we have initiated a study, I mean not officially on behalf of the Endocrine Society, but members of the Endocrine Society across the country, multiple city study has been done, and we are awaiting the results. And I showed only a part of the study that pertains to our center in Calcutta. Thank you.
Yeah, thank you. Another point, just only one point, last point, please give me.
Excuse me.
Yeah, the reference range, and we have generated the reference range in Apollo Specialty Hospital, and we have given it to the other feeding hospital in our population. It is as the other things, it is not very difficult. It can be done. It is very easy. If what you would like to have is only 100 number of subjects you should have. From those 100 number of pregnancy subjects, for each trimester, we can definitely generate a reference range. If you have any problem, you can please contact me. I will be very happy to help you in generating a reference range for a local hospital or a local region. And this will definitely give better outcome, for your, in managing the pregnancy, thyroid diseases during the pregnancy. That is the point, I would like to again emphasize to your community. Thank you very much.
Okay, so
Yeah, you can continue the same dose during the proliferative as, because you are giving once a week therapy. So you can continue the same. And what they have found is the median dose in a patient with microadenoma, microprolactinoma, is around 0.5 mg per week. So it's a very small dose. I think you could continue the same dose.
One question from me to Dr. Chaudhary. In a case of post-thyroidectomy with supplementation and she becomes pregnant, does the same parameters hold good there, or do you have to look for something else?
So post-thyroidectomy, hypothyroidism on thyroxine. Here, if a woman is planning to get pregnant, we as physicians suggest you can increase the dose as soon as you know you are pregnant, increase the dose by about 25%, and then recheck because of the increasing dose requirements in pregnancy. However, in my practice, I have found that quite a few of these ladies do not actually require an increase in dose. So I personally possibly ask them to get a test as soon as they know they are pregnant, and then decide as to the dose increase. But there is standard recommendation that you increase by 25 to 40%. But what was your exact question? Did it answer?
The parameters also.
The parameters would be about the same. I mean, as to the targets that we want to reach, yeah, they are the same. Yeah, 2.5 in the first trimester and 3 TSH value in second, third trimesters. Yeah.
Pre-gestational diabetes.
Excuse me. So if it has been a thyroid malignancy where pre-pregnancy you try to suppress your TSH.
Yeah.
So in pregnancy, do you still want to maintain the same level, or you would try to relax your dose?
The suppression, the TSH suppression that we take recourse to in cases of differentiated thyroid cancer, the degree of suppression is now understood to be less stringent these days, especially after the first maybe couple of years, especially if it's been a low-risk papillary carcinoma. But nonetheless, if in the context of pregnancy, fortunately, and which is somewhat surprisingly different from the non-pregnant state, suppressed TSH values tend to be tolerated somewhat better in pregnancy than slightly elevated TSH value. So by and large, as I said, a suppressed TSH suppression is normally up to about 0.1, anything between 0.1 to 0.5. And those values are actually even seen in some normal pregnancies. So we are not unduly concerned about that degree of TSH suppression, not gross severe TSH suppression less than 0.005. We don't go to that level in any case in cases of differentiate thyroid cancer follow-up.
One question to Dr. Ganapathy. Suppose macroadenoma lady, she becomes pregnant and the pregnancy, she goes through pregnancy uneventfully. Can she withstand the strain of labor or should she have elective cesarean section?
It's preferable for elective cesarean section because during labor, because of the stress of the labor, there can be problems. So that's why they have recommended cesarean section during that time for a macroadenoma. For micro, no problem.
And you suggest she has to have the cabergoline in the postpartum period?
No, not required. Suppose if it is it's the estrogen which has a stimulatory effect on the lactotrophs. So postpartum, in fact, they have found in these series, at least 20 to 30% have a reduction in the prolactin level. Microadenomas, 20-30% will disappear also. This is because of the vascular changes. Microinfarction may happen. Infant suckling has to be encouraged. So though there are anecdotal reports, nipple stimulation can increase prolactinoma size, but then it is very, very rare. So the rule is encourage suckling, need not give cabergoline during your postpartum period, unless you feel that there are symptoms of headache, all these things, then we'll have to reintroduce it.
Sir, madam, I have a question.
In pre-gestational, I've been standing just a minute. In pre-gestational diabetes, the advantage of analogs, you emphasize the importance of insulin, and you also gave us the class recommendations. Is there any, what do you think is the clinical advantage of analogs over the regular insulin? Maybe it's nice to have both from Calcutta, and we got true academician as well as a featured speaker of the pharma, so we'll get balanced. You can also contribute here.
Yeah, so as long as you can control diabetes on human insulin, it is good enough. Simple. If you are not able to manage sugar controls with conventional insulin, you can use analogs. You know that analogs are much more rapid acting. It causes relatively lesser hypoglycemia. It causes relatively better prandial control. If you are not able, there is no hard and fast reason to believe that analogs are superior. I never said that. None of the guidelines says that. The point remains is, if you can control patients' HbA1c under target with the available insulins, it is good enough.
The issue about rapid acting, we all know that why we do 3 hours extended GTT in pregnancy is that the GI tract is a bit, maybe lag. So if you give rapid acting insulin, that itself may not, correlate with the physiology. So there are some people, not in India, there is one Singaporean pediatrician, he said that if you give complex carbohydrate, and the vitamin D is all, of course, vitamin D I don't know how to supplement, a good diet, which is rich in regular insulin is as good as, but in this city, very often we are being bombarded with the data from the pharmacy funded trials that analogs are much better, So the clear cut, I just, at least in St. John's, what do you do? Let us move back to, and in Calcutta, yes.
See, we use human insulin itself. So when do we use analogs? So one thing is everywhere we are, because it's an FDA, all the insulins are FDA category B, so we are using human insulin. But then there are exceptions where we use. One is you find in spite of using this, we reach the target of postprandial less than 120, and we are still finding a macrosomia. So then once we start increasing the dose, we are getting hypoglycemias, and then we start targeting the 1 hour value. And if we find that the 1 hour value is more than 140, this is a place where I would like to use an analog, because analog are rapid acting, could target the first hour. Otherwise, the usual trend is using human insulins. So these are the place where I may use an analog when I find a macrosomia, in spite of increasing in the human insulin, patient is getting hypoglycemia, and then when I start targeting the 1 hour value, I would like to use analog.
So not all it's selected.
A final question from Mike 4. I think we have had enough discussion in analog. Since we are running short of time, a final question from Mike 4.
Good morning, sir and madam. I sit in the Endocrine OP at Madras Medical College, and I have a lot of cases coming from Gosha as well as IOG Egmore. I have two patients coming with previous fetal loss, and they come with TSH absolutely normal, 2.5 or even less, and we have high antibody titer. And then because they come pre-gestational, I do start them on a very low dose. I'm in a doubt, no proper guidelines, but nevertheless because of the fetal loss, I give a very low dose of 12.5, sometimes 25 microgram. And then once they become pregnant, the TSH drops during the first trimester of pregnancy due to the beta-HCG effect. And then I'm in a dilemma. Should I continue or not continue? Could you kindly advise?
There's no clear guideline on this. It has to be on an individual basis, and in fact, if you go by the lab reports, the lab will say the normal range is up to 4.5 or 5, and you have actually got to discuss with the lady why you are starting on thyroxine, because of evidence, maybe even with antibody positive women being treated, there is some evidence. And you have to make it clear to them, otherwise they would say, I have got my TSH within the normal range, why should I be treated? So if you are committed yourself to treating, if the TSH in the first trimester drops, but if it's still within the normal range, I think you can continue. But again, the starting in this situation is, in the situation that you mentioned, is not what I would do.
Thank you.
Yes. Sir, my question to Dr. Ganapathy. Sir, in patients who are amenorrheic and come for subfertility management, we see that the prolactin levels are like borderline, around 30, 40. We start them on Capgolin maybe for 2-3 weeks. But what is the follow-up? Like, when should we invariably after a month, if we see the prolactin levels, they do drop quite low. But what is the follow-up? Like, when should we go back to check on prolactin again? And what's the treatment after that?
No, suppose you have I'm talking even of a microadenoma. Whenever you are using a dose, you just started, it has to be checked after a month. And once it is stabilized, then you can do it less frequently. But then the rule is, after the month, you must do the prolactin levels.
Yes, sir. After 1 month, it is low. So when should I check it again? Like, because I'm treating for infertility or subfertility. So when should I check the prolactin levels again? After 3 months or 6 weeks, like
after
thyroid?
3 months, you can check. The next check will be after 3 months. But then if you have stopped it, then maybe after 6 weeks, you can check so that you know what has happened. And then suppose you see, because there are some patients who can have intermittent elevation of prolactin. So you find one day normal, the next 2. So in them also, it has been suggested that if there is an infertility and there is a marginally more, 1 or 2 points more, then also you can treat it.
So thank you. I think we were running short of time. Thank you, speakers, Dr. Avdesh Kumar Singh, Dr. Subhankar Chaudhary, and Dr. Ganapathy Barwal. And thank you, Jayashree Madam.